Well, let's talk a little bit about emerging therapies. Tom, you want to get us started off talking a little bit about how genetics and other subsets in the relapse setting might help shape what we're doing or how we think about treatments that we have available currently in the relapse setting.
Sure. In contrast to upfront therapy, cytogenetic abnormalities, the high-risk abnormalities, obviously have been associated with worse prognosis, but when the patients receive a daratumumab-based regimen, they in fact do better. So Jonathan Kaufman presented data at ASCO looking at data from the Pollock study, and Kaja Wiesel also presented data looking at from the Castor study. And in both of those studies, patients who had high-risk disease did better, much better, in fact, if they got Dara plus the doublet, either lenalidomide and dex or the doublet bortezomib and dex, than you would have expected based on the frontline data. Pretty interesting, in fact. In fact, the patients who were high risk that got the triplet did better than the standard risk patients that got the doublet. So it didn't completely eliminate having high-risk disease. They didn't do as good as patients who are standard risk getting the triplet, but it made it a lot better, in fact. And so there is a little difference there between newly diagnosed and early relapse patients. I do think that if somebody has high-risk cytogenetics and has early relapse, going to a daratumumab-based regimen, one of these regimens, DVD or DRD, or even DPD would actually be okay. And I do think actually a carfilzomib-based regimen would be fine in addition, triplet.
So how do we reconcile what Saad was saying earlier in terms of Alcyone, Cassiopeia, and Maya, where you don't get the benefit from adding Dara, and what you're saying with Pollux and Castor, where you do seem to get the benefit? I'm trying to figure that out.
So are we. I think it will have to be longer follow-up. I think my critique of Maya is, again, the small proportion of high-risk patients that they have. It's only about 14%. So that's roughly 26 or 27 odd patients on each arm. And it could be just the luck of draw that we are not getting the same answer. But again, with longer follow-up, the answer may be a little different. I think Alcyone read out with a follow-up of 16 and a half months, something like that. And I don't think we're going to see major differences in PFS for high-risk patients that early on. But we'll definitely see it by 3 years.
Yeah, I mean, it certainly could be that the truly high risk fall out early on, and they never even get to the relapse trials. And so what we're calling high risk in relapse is not the same as high risk in newly diagnosed.
High risk out of the gate is probably really bad. But again, like you're saying, high risk down the road isn't as bad as right out of the gate, without any other therapy, without any selection, et cetera. But again, we'll learn more over time, for sure.
So let's get to a happier topic. You want to talk to us about optimism. Let's talk about optimism. Saad?
So Optimism was a randomized phase 3 trial that compared pomalidomide Veldex versus Veldex. And when I looked at the abstract, I thought the P stood for panobinostat because the data looked very similar, but in an earlier relapse setting. In the US, most of our patients do become len refractory fairly early on, and we always struggle with the best options for those patients. So I think from that perspective, looking at that first relapse population where POM Veldex actually did have almost 21 months of PFS benefit compared to 11 months, I think it's a reasonable option. Will we be giving Velcade the same way that it was given in the clinical trial? Probably not. So I think it's a decent option for our patients who are len refractory. One abstract that I didn't see here is Ikara. It might be the next one that we talk about. Yeah. So I'll just leave it at that. I think I think that would be an important option to discuss in the same space. POM Veldex, I think both high-risk and standard-risk patients benefited in the subgroup analysis. So again, even though they might not be the same high-risk that they're in the front line, that's an important distinction, especially for deletion 17p patients, I think.
Yeah, so Amrita, I know led a trial of POM Ixodex. Do you want to talk about some other POM-based approaches that were discussed here?
So, Saad referenced the ICARA trial. So there, are other anti-CD38 monoclonal antibodies. So isatuximab, and this was a large trial, phase 3, comparing Isa-Pom-Dex versus Pom-Dex alone. And, not surprisingly, it showed higher response rates with the Isa-Pom-Dex, better PFS with the Isa-Pom-Dex. So I don't think there's any argument about third drug, and I do think the antibody POM combination is probably one of the best combinations we have. I think the question, which I'm sure you're going to ask everyone, is what do you do with that in the setting of daratumumab? And I didn't come away with an answer for that from this trial.
All right, what do people think? So we've got DARA, we will likely have ISA, I think based on this trial. It's clearly a positive trial. I think there were some discussions around the ability of one, or whether there is any ability of one to work when the other doesn't work. I don't know. What do you all think?
I mean, we've done that in a number of patients. We've treated a lot of patients on isatuximab at UCSF, and then when we tried to go to daratumumab afterwards, we really haven't had a long benefit, probably a very short PFS, and vice versa too. We've, I would say we've tried a small number of patients who received isatuximab to give them opposite daratumumab to give isatuximab, and again, we didn't really see a huge benefit there. I think it's going to be difficult. I think if you're going to give two CD38 antibodies, they have to be separated by a period of time to potentially allow for CD38 expression to recover on some of these myeloma cells. In terms of the phase 3 data, it's really good phase 3 data. It's a large study. It's 11.5 months PFS. In terms of antibody plus Pom-Dex, it's the longest of all the studies that have been published at the current time. So it works really well. With daratumumab coming, I think, into the frontline setting, I think this would be a reasonable strategy. And this study was for people who had 2 prior lines of therapy. So they get daratumumab frontline, they get a second line of therapy, and then this would be a reasonable thing for third line, and that would be 2 prior lines of therapy. But I do think they're partly interchangeable in terms of what regimens they can be used with.
So I think we didn't touch on Elo-Pom-Dex as a potential option, and I honestly was discounting Elo in a post-DARA exposed or refractory patient, but I've been pleasantly surprised with some of our experience with E-Pom-Dex, Elo-Pom-Dex in DARA exposed or refractory patients. So if you're thinking about a monoclonal in a post-DARA, first relapse, I find that the E-Pom-D data is fairly similar to what we see with Isa-Pom-D. So again, the struggle is, are these drugs equivalent? And if they are, then it's better to change the target with the monoclonal antibody. I think that's where we are going to be struggling with clinically.
So
I would be,
go ahead.
I would be curious in terms of your Elo-Pom-Dex patients, with those immediately after progressing on DARA, you switched to Elo when you saw responses?
So right now, most of our DARA usage is in the first or second relapse setting. So then, for our patients who are progressing on DARA, as we're thinking about different MOAs, and if we've already exhausted our PI options with previous lines of treatment, then we're left with Elo-Pom-D, and we have been pleasantly surprised. We've salvaged some patients where we thought it wouldn't be possible.
Yeah, if you're using an IMiD, that NK cell concern that is there with DARA goes away because you get nice recovery of NK cells with an IMiD. So I think that's certainly one way to think about it.